Hello, everybody. Hi, everyone. We're just, people are trickling in. Just going to wait a minute so that everybody can join. Very nice to see a lot of people here. Thank you so much for joining us today. It's really great to see that there is great interest in the topic. All right, I think we can get started. So welcome everybody. So this is the webinar on routine measurement of outcomes for patient and clients from the voluntary and community sector services. That includes social prescribing. So today we're going to have three speakers from Bromley by Bow Center, Aging Well Torbay, and sorry, I forgot the last one is. Can you help me out?
Weight wellness.
Yes, thank you. So we'll have three presentations from the three speakers that are with us today, and we'll have questions for speakers as well at the end of the time via Slido. So I'm going to show you a little bit more about Slido. So you can either join the Slido event through the link, the direct link that I'm going to put in the chat now, or you can just go to Slido and enter the event code that is indicated on the slide and in the chat. So at all times, you can go on this link and ask questions for speakers. You can vote for which questions you would like to be asked and this kind of things. And at the end, we'll go back to that and we'll be able to kind of answer them. So at any time during this this webinar, you can just kind of input your questions via this link. We'll also be asking you some questions at the beginning and at the end of the webinar, so you can see them on your screen now, hopefully. But yes, the questions will be on Slido as well through the same link. We are recording this webinar for sharing after the session. So if you do not wish to appear on this recording, please keep off camera. And finally, if you need anything, if you have any tech queries, if you can't hear this kind of things, just message me via the chat or by email. I'll put my details in the chat box in a minute. And now I'll hand over to Jane.
Hi, welcome everybody to this lunchtime webinar on measuring what matters to communities. And I'm going to the chair for this webinar. I'm really delighted to do this. And just to introduce myself, my name's Jane South. I'm a professor of healthy communities at Leeds Beckett University, but I'm here today in my role as a national advisor on communities for Public Health England. And Public Health England has had a long relationship with Bromley by Bow, particularly supporting evaluation and disseminating the learning that's come out around measurement. And that's because Public Health England see community-centred approaches like Bromley by Bow as being really critical for reducing health inequalities, and also recognise the innovation and learning that there's been in this centre and the potential to spread that learning far and wide. And this webinar is very much part of that. So today we're going to hear three really fantastic speakers on groundbreaking projects, and I'm really delighted by the having seen what people are going to present, by the kind of real content and experience that there's here in this room today. And all these projects are tackling or have tackled the perennial challenge of measurement, and the context of that is, of course, of measurement is understanding, and I'm sure everybody on this webinar will know this, but understanding the importance of the voluntary community sector and communities for people's health and well-being and for reducing health inequalities. And we've seen particularly the focus is on schemes like social prescribing, which we've seen emerge and gain popularity really across the health system as ways of connecting communities and people to services and vice versa. And I think that connection is never more important than in the time of COVID, is it? Where the strength and resilience and the connections that community and voluntary sector organisations bring is absolutely critical for how we manage the pandemic, but also in recovery. So this session is focused on outcome measurement. And I know from being a researcher in this area, it is really a perennial challenge, outcome measurement. Everybody wants to capture what happens in communities and what community and voluntary organisations do and what happens to people who are involved in them, because we've all seen that transformational change that often happens with people when they become involved. We've seen the growth of connections, the life opportunities, and a lot of us here want to be able to demonstrate that change in a way that convinces others. And sometimes those others are funders and commissioners of work, so we can carry on working in that way. But I think many of us will recognise just how hard it is to nail that one, because services work in really holistic ways. They're very person-centred, and that doesn't necessarily fit very well with how we've all been taught how to measure things. So the goal really is to try and bring those two worlds together and come up with outcome measures and ways of measuring that do capture the value of the work, the connections, the empowerment, the inclusion, the confidence people have, their personal growth, and to do that all in ways that are rigorous, but also true to the values. And that's what we're going to hear today, I know, from the three presentations, what's been happening. So the aim of this session is very much knowledge share, not training. And it is contributing to a community of outcome measurement practice, and more of that later. So we're going to hear from three very different person-centered approaches. So I'm going to just quickly introduce the speakers so that you know who will be on just before we move into the sessions. So we've got Dan Hopewell. Dan, do you want to give us a wave? Director of Knowledge and Innovation at Bromley by Bow. And Catherine Godward, Research and Evaluation Manager at Bromley by Bow. And Catherine's going to take us through the work that's been going on over the last year around developing a common outcome set. Then we've got Simon Schuberski, Director of Ageing Well Torbay. That's a National Lottery Community Fund National Test and Learn programme to test innovative ways to reduce social isolation and loneliness for people over 50, and which is called, the national programme's called Ageing Better. And Simon's going to tell us about the work they've been doing in Torbay, and I think many of you will know about Torbay because there's been a lot of information about that around. And then from the completely, utterly, geographically other end of the country, Chris Drinkwater, delighted to have Chris here, who's the chair of Ways to Wellness. And that's a social impact on delivering social prescribing at scale for people aged 40 to 74 with specific long-term conditions. And Ways to Wellness is based in Newcastle, the Northeast, and has been going since April 2015. So I'm now going to hand over to Catherine and Dan to start the presentations with the presentation on the Bromley by Bow outcome measurement.
Great, thank you so much, Jane, for that wonderful introduction to today's webinar. And I'm going to give a very, very brief introduction to the Bromley by Bow part of this webinar. I'm Dan Hopewell, Director of Knowledge and Innovation, and Catherine Godward, who is our Research and Evaluation Manager here at Bromley by Bow. And our programme is called Unleashing Healthy Communities. And as you said, Jane, this started off with some really key collaboration between Bromley by Bow, the Health Foundation, the Wellcome Trust, and a private partner, OCS, around understanding the Bromley by Bow model and how we might measure it, and understanding how we might measure what matters to communities. And through doing so, making what matters to communities visible and understood by the systems as well. If we could go on to the next slide. I'm just going to talk Catherine, on to you for this one.
So yeah, today we're going to cover three main areas. We're going to give an overview of the Bromley by Bow model. We have a quantitative and a qualitative programme of routine outcome measurement, but today we're going to focus on the quantitative approach, looking at goals, the scope, the development stages that we've gone through and how the approach works in practice. We're also going to cover what next for Bromley by Bow outcome measurement. But over to Dan now for item 1.
So this is very, very brief introduction to Bromley by Bow to give some context to the outcomes framework that we've developed. Bromley by Bow grew out of a dilapidated church in East London. Hard to imagine what East London was like in the 1980s, although I lived there at the time and remember it was a borough that nobody wanted to live in whatsoever, and a site of huge deprivation. And it still is incredibly challenging. But out of that, Bromley by Bow developed one of, well, I think the first healthy living centre in the UK, a hybrid model of primary care and community provision. And as Jane has alluded to, really, the perennial challenge of how do we measure and understand the outcomes that are achieved by that. And so we embarked on this journey of developing an understanding of our model and an understanding of how we might measure that. And very much in the spirit of Bromley by Bow, which grew out of a community developing responses to its own needs, but also to its own interests and passions, the outcomes framework has been developed through community research in terms of understanding what's meaningful to our community and therefore how we might go about measuring that, both across our clinical services and our non-clinical services, which is also an incredibly exciting prospect. I'm going to hand over to Catherine now to talk really in detail about the Unleashing Healthy Communities Outcomes framework.
Thank you. Before I progress, can I remind people to answer the questions that are currently in Slido? So, as is the case for all the presentations you're going to hear today, Bromley by Bow has developed a person-centred approach to outcome measurement, which matches the person-centred approach to service delivery. Bromley by Bow's objective has been and is to develop a whole organisation outcomes framework and methodology. And this has relied on changes to both internal systems and the culture of data collection and outcome measurement. There have been 4 key aims to this work. First, to channel and amplify the voice of the local community, for clients to say what's working and what's not based on what matters to the community most. Second, to gather evidence needed to inform service design and development so Bromley by Bow can remain responsive to need, improve delivery and translate the client perspective into a case for funding. Embedding a consistent cross-organisational approach gives the data more weight and it saves us money and time, not having to start from scratch each time we deliver an activity or have a new activity funded. And 4, to create the least amount of disruption as possible. Bromley by Bow has built a consistent approach to measurement across different sites by embedding within different pre-existing systems and processes as far as is possible. For example, practitioners asking questions of clients within the usual approach to contact. The scope so far includes community and non-clinical health services across Bromley by Bow Centre and Health. So at the moment, that includes 40 social and health projects, excluding routine GP appointments. And in terms of the numbers of clients, patients who sign up to these activities, it could be less than 50 to more than 500. Lots of different delivery types. This doesn't list all the different types, but you can see that they're quite different, some long-term, some very, very short. Lots of different focuses of activity. Again, this doesn't include everything. And we've been working with approximately 60 people across 11 teams within Bromley by Bow. Eventually, we want to accommodate all projects and routine GP appointments. And when we do this, this would include approximately 30,000 patients and 115 more people to work with across 3 surgeries. The Bromley by Bow Outcomes Framework is a result of 2 years of consultation with members of the community through the community research that Dan just mentioned, to identify the ingredients of a good life from community members' perspective, set within a current and historical context. Community in this case means residents, practitioners and staff. All responses have been collected into 6 outcomes: basic needs met, strengthened personal resources, connection to others, built knowledge, skills and opportunity, connection to place and community, and contribution to the community. And these outcomes are what matters to communities. The stretch element of each accommodates the possible range from a foundation to a growth level. So in the case, as the example here, contribution to the community, a client might feel motivated at the end of an engagement with Bromley by Bow. They may equally feel that they're helping others, or they may actually be helping others, and both are valid outcomes. This slide sets out the outcome domains, illustrating what each of those 6 stretch outcomes covers. There are 14 into which the 6 outcomes have been operationalised through the next stage of the research that I'll come on to in a minute. And as you can see, in every case except for basic needs met, wellbeing and other, the foundation growth element has been captured. So these have been turned into 40 indicators through the next phase of this work. To find out what change looks like and an approach that works, we've consulted with internal and external colleagues, conducted a service delivery audit, reviewed approximately 20 non-Bromley by Bow validated and non-validated tools, and lots of tools that were in existence and use within Bromley by Bow, and crucially consulted the very experienced external advisory group that this project works to, and the internal advisors across Bromley by Bow Centre and Health. For the 100-day challenge, Bromley by Bow conducted in-depth discussions with 12 groups of staff that covered all 40 projects, essentially asking what does realistic and achievable change look like for clients. The result is a tool designed to be used for every client, made up of bespoke and validated indicators with 14 domains, 36 subjective indicators asked at the close of an intervention, and a hybrid of ONS4 and the personal wellbeing score developed by our outcomes, which itself is a very slightly reduced version of ONS4. And this provides a pre and post measure of wellbeing. We're also in the process of getting a MyCore license. Bromley by Bow codes presenting need to intended stretch outcome to monitor need against the outcomes framework. All data is collected, administered by practitioners and service delivery colleagues, and the approach is built into existing Bromley by Bow databases. We've developed a bunch of supporting resources, so logic model, outcomes, commentary, user journey, data map, for example. Before I move on to the user journey data map, I'd like to share some of the results of the indicator selection within teams. So common to all projects except for one-off short events, for example, the ONS4 personal wellbeing score hybrid, and any other change is asked. That's a sort of common across most projects. And then what's listed here is the top 10 indicators that have been selected by teams. And as you can see, there's quite a mix of both foundation and growth level here. So moving on to the user journey data map, this diagram illustrates how everything I've just talked about works in practice. So focusing on data collection points, the diagram maps a client's linear journey from first being in touch with Bromley by Bow through to the close of an engagement. However, the linear journey is often not that usual. Clients may engage for one point only. They may skip points, moving from initial contact to registering for an activity, or engage in social prescribing and bypass the activity. Bromley by Bow's approach measures change after an intervention, and that includes the first social prescribing conversation after an activity has closed, and at the end of all social prescribing conversations combined. And as you know from earlier, that means capturing a wellbeing baseline, and we need some data that illustrates service need. So data share when somebody first registers or is in touch with Bromley by Bow at journey points 1 and 3. So when somebody does first register with Bromley by Bow, the blue blob here illustrates the type of information that is shared. So demographics, referral source, prior experience of the service user, and from this we capture service need. We use a bespoke tool to do that, and it's administered by the project delivery team. During the first social prescribing conversation, presenting need, roots of someone's problems, their goals, their plans to achieve those goals, and also outcome from social prescribing so far from that one call. That's the type of information that's captured at that point, and that gives us service take-up, presenting need mapped to intended stretch outcome, a wellbeing baseline, the stretch outcome, and we're also going to be capturing some information on call satisfaction. And we can see here that the tool that we use is a hybrid of bespoke indicators and variables, MyCore and ONS4. And as I mentioned, that's a hybrid in itself, the version that we're using. And a link worker will administer this. We capture service need and wellbeing baseline data at the start of an activity, again using a hybrid tool. And we measure change at the close of an activity. And from this, we find service take-up we find out the stretch outcomes, the wellbeing outcome. Again, we use the hybrid tool. And then after all social prescribing conversations, we find out change in terms of the stretch outcomes, the wellbeing outcome, as a result of social prescribing. So not accommodating the activities that somebody may or may not have taken up on the basis that they may not have taken up the activity. And also we capture change from the activity elsewhere. So as well as ongoing implementation, in terms of what next for Bromley by Bow, there are a number of activities that we would like to develop and implement. We'd like to look at long-term change. We'd like to conduct a longitudinal study where we capture outcomes, we capture service take-up. We'd like to do this with a match site, perhaps overseas. We want to be able to establish contribution, so looking at external sources. Also, we're very interested in the ripple effect that Simon from Ageing Well Torbay is going to share in his presentation today. We want to do similar work at a community level, so develop an adapted framework that looks at across the community rather than the component parts. And for this, we need to develop a new methodology as well. We want to look at patient-client flow between the community centre and the clinical setting. To do this, we'll need to have anonymised data sharing, consistent outcome measurement across each setting, but this is something that we are committed to. So thank you. I hope that you found it useful to hear about the approach Bromley by Bow is taking to routine quantitative outcome measurement and areas of work we'd like to develop. I'm now going to hand over to Simon Schuberski from Ageing Well Torbay.
Thank you, Catherine. I wish my slide deck was as whizzy as yours. Thank you. So Ageing Well Torbay, as previously stated by Jane at the beginning, is part of a National Lottery Community Fund test and learn programme, and there are 14 sites, of which we are one. We had the benefit of securing significant resources through the National Lottery to be able to run a programme for 6 years. And I'm pleased to say it's just been extended for a 7th year. Next slide, please. So I just want to sort of highlight some of the key principles of our approach to partnership working to tackle isolation and loneliness for older people in Torbay. We don't do anything without engaging with the people and listening to them. We have a key principle and practice, and it's a large part of our programme, which is to draw on the strengths and the assets of the people and the places in which they live. We've co-designed collaboration and approaches and found ways to involve the people as part of the solutions. And they're also involved in the governance of the programme. And I think that's a really important point, actually. So our programme board has more older people on it than it has representatives from statutory or other agencies. So I think we're on target. We've engaged thousands of isolated people over 50. We could do a whole other slide deck on how we've adapted to deal with the pandemic, but that's maybe another session. So Ageing Better, the Lotteries programme, has a national evaluation partner, and that's Chorus, who designed a common assessment framework, which is questionnaires that are taken periodically through time at the beginning and then periodically until those people exit, if they do in fact exit part of the programme. Next slide, please. I think one of the things I want to highlight very strongly for anyone wanting to be able to capture data is the importance of what here the jargon says CRM, a customer relationship management system. I'd like to acknowledge, I think it's Middlesbrough, who one of the other test sites, who put us onto a system called Apricot, which is our CRM system we're using for all the partnership activity, allows people to link between different elements of the programme and the partnership. And we've actually now used it for other partnerships and our new community helpline, which was our pandemic response. Without that data capture tool, it's very difficult to actually demonstrate what impact you're having. As well as that CRM system, We also have quarterly reports from all those organisations involved, and they all have their individual KPIs in terms of the contracts that they were commissioned to deliver, milestone reports, budget reports, some of the key challenges in the period, their learning, and always, very importantly, case studies about what a difference it's made to people. So I just want to focus a bit on story capture and highlight the link there. I'll put it in the chat space in a minute, but we've got some lovely stories of people's lives changing, and some of those are contained on that link there. So it's not just about capturing quantitative data, it's also about capturing the stories of how lives have changed as a result of our joint work. Next slide, please. As well as having a national evaluation partner, part of this programme also was for us to have a local evaluation partner, in our case CIRIO, which is part of University of Plymouth, that should say, not Plymouth. And so CIRIO, we commissioned CIRIO to work with us, so they do further analysis of all of the questionnaire data, and I will post a link to one of the questionnaire examples. A number of the questions on that questionnaire are very similar to some of the things you've heard from Bromley by Bow. What CIRIO have also done, because we wanted very much that sense of co-production in our approach, is they have recruited people that we've put them in touch with, citizens in Torbay, all over 50, who they've trained up to be citizen evaluators, who have then gone and interviewed participants, volunteers, staff, run focus groups, and that's all feeding into the CIRIO reporting. And we can, on request, give you some of the detail of some of that reporting. They also review all the learning documents that we've produced that you can find on that link that I've posted in the chat space. And they've held quarterly forums with partners, with participants, and those who've benefited from the programme. The technical report has just been published, and we can make that available to anyone who wants. Next slide, please. So just to dwell a bit on some of the measures that people may be familiar with that are built into the questionnaire or the CMF system. So I'm sure lots of you will have heard of Dijon. So that's one of the elements of the questionnaire that we've managed to capture. And because the program's been going on for some 6 years now, we're able to see change over time. And there's some highlights there I won't go into, but the largest change actually been seen through our neighbourhoods project, in terms of shift from state of loneliness to feeling less lonely and more engaged and feeling more a valued contributor in the local community. Within the link I posted earlier to agingwell.com/legacy, we have a number of short learning documents. One is about community building. So in Torbay, the core of the programme, if I can call it that, is what we call a social prescribing ecosystem. We have wellbeing coordinators, very similar to social prescribers, who are hosted within Age UK and Brixham Does Care, and they have motivational coaching conversations with people, often in their homes, at least it was pre-lockdown. One of the strap lines for that is as many cups of tea as it takes to build a relationship with an individual, and for them to come up with what kind of life they'd like to lead and what kind of changes they'd like to make. And those wellbeing coordinators then work closely with our team of community builders. That's the neighbourhoods element of the project. So we have a team of 15 full-time equivalent community builders trained in the art of asset-based community development, with added benefits of using tools like time banking, for example. Now, the key to that approach is there's no start and there's no finish. You know, those community workers are out in neighbourhoods, building relationships, building trust, connecting people up around their shared passion and energy. And what's come out of that is lots of the people, some of whom were previously isolated and lonely, actually getting involved and running activities for themselves and others. And I think that's the bit we probably want to amplify in terms of the Torbay approach. We see everyone as a contributor, not a patient or a service user or a beneficiary, but as an active contributor. And when we walk with the community in that way, we see significant change happen. And if you go to that Link Aging Well legacy, below the learning documents, there's some lovely video segments there where you can hear people talking about how their lives have changed. Next slide, please. So the other loneliness scale that we use is the Campaign to End Loneliness Scale. And again, the questionnaire enables us to look at what difference has been made on that scale too. Next slide, please. And if that wasn't enough, we've also got the UCLA loneliness scale. So us and the 13 other test sites all have data on this, and the lottery has also produced, with our choruses, support, national learning and impact data that you can source through those two organisations as well. Again, there's some highlights of some of the statistics there. What you can see also in our learning documents is significant change being made by working in this way with people. Next slide, please. So these again, I'm not going to go into the detail of this, but these are some of the data that's harvested through those questionnaires. There is a slight challenge with the use of a questionnaire that is some 20 pages long, in that actually it takes quite a lot of time and energy. So, you know, I think as we develop the practice, we probably need to hone down and as Bromley by Bow have already advocated, find ways to sort of incorporate it into the practice so it doesn't become quite so onerous. So the balancing act there between capturing data and actually doing the practice itself. But you can look at all these figures at your leisure in the slide deck when it's posted afterwards. Next slide, please. Maybe I just want to highlight the one at the bottom. But actually, we have another statistic which isn't actually raised here, which is my favorite statistic. So we asked the question in the questionnaire that I'll post shortly, how able do you feel to use your skills knowledge in your local community? And at the start of the process, the percentage was 23%. And later on in the process, that more than doubled to 56%, which tells us that we're doing the right things to enable the people to get involved and be part of the solution, both for their own sense of personal value, but also for the wider community in which they live and interact. Next slide, please. Recognizing that questionnaire data comes with some challenges, we also, for the well-being elements of our project or partnership, captured NHS numbers with a view to then interrogating health and social care data. If I just point you to the Torbay element, which is the second segment in the green here. So this, because we captured that, we passed all that anonymized data to our colleagues within our local foundation NHS trust. And they looked at those people and what activity was happening within their budgets. So emergency duty, inpatient, outpatient, and community health and social care. They looked at 12 months prior to the people engaging with our wellbeing coordinators and 12 months post working with our wellbeing coordinators, and looked at the difference in demand. Well, what's interesting is the amount of negative figures in the right-hand column, the percentage change. The only one that's increased, well, 1 by 1.7 in outpatients, but social care an increase of 42%. All the other elements of the health data that we were able to interrogate show a significant reduction in demand in those health services. Just in case anyone's looking to make comparisons between Torbay and South Devon, they are different cohorts of people. So the people that have been supported through the wellbeing service in South Devon were significantly older than the people in the Torbay cohort. So please don't make a direct comparison between the two data sets. I think it's probably fair to say that the degree of complexity with some of the people in Torbay was more significant. Maybe that advocates to all of us to work with people earlier on wherever we can. Next slide, please. So one of the challenges I mentioned, half our programme is effectively our asset-based team of community builders hosted in our trust. Now, in that model, there is no start, there is no finish. It's not a service intervention, it's enabling activity in a community or in a neighbourhood. So one of the things we're doing in the 7th year of our programme is exploring another form of evaluation, which we think might be a better fit within that complex community space. I just want to acknowledge and thank Dr. James Nobles from the University of Bristol, who has shared some of his learning of working with Gloucester Community Builder Collective using ripple effect mapping. It has been used in other parts of the world, not so much in this country, but I think James will be publishing some learning on this later this year. So one of the challenges of capturing information in the complex community space is often evaluators want to gain a sense of attribution, is the jargon. Ripple effect mapping looks at contribution. As far as I understand it, and I'm not an evaluator, this comes under some of the auspices of developmental or realist evaluation. Assessing contribution, as I said, using workshop-based appreciative inquiry techniques and structured interviews, focusing on what actually happened, the key events, the successes, the impacts, but more importantly, the unintended as well as the intended outcomes and relationships and connections. So we're going to be testing this over the coming year to see whether this might be a better way of capturing what actually took place, because often what happens is not what we intended. Next slide, please. So although slightly simplistic, and thank you, James, I've nicked a little bit of your slide deck. So in a kind of standard evaluation, this one was around, I think there were Bangladeshi women wanting to learn how to cycle. So standard evaluation would tell you this many people completed the cycle training, of whom 6 were classified as inactive. At the end of the training, 6 people completed it. And then 2 were then classified as inactive. Next slide, please. With ripple effect mapping, by using those slightly different techniques, you start to gain a broader picture. So 10 people completed the cycle training at the start, and then you've got the 2 of those started a local cycling group. And actually now there's 30 people regularly attending the cycling, all of which wasn't necessarily part of the original intended outcome. But you've got a second ripple. Several of those people noticed actually the local streets weren't very safe for cyclists. One of them spoke to a local councillor, and that has led to the council working with those local residents to improve the infrastructure to enable more people to cycle. Next slide, please. So here's another example of a ripple map. And you can't see the detail, and that's deliberate. But this is the same piece of work amplified through those workshops and structured interviews. And then you probably can make out some different colored boxes. So as you build your ripple effect map, you can start to codify the types of themes and things of interest, which aren't just the actual outcomes, but might also be the connections and the relationships that were formed. Because connections and relationships are a very important part in the community space of actually gaining a whole load of unintended and ancillary outcomes and benefits. Next slide, please. Just some lovely quotes, really, from some of the people we've worked with about how we've actually helped them change their lives. You can read this at your leisure later on. Next slide, please. And that's the finale. If anyone would like to contact us to find out more information, sorry about the black line down the side there, but my colleague John Arkos, who's our program manager, will be happy to facilitate access to further information if you so require it. Thank you very much indeed. And I'll pass over to Chris from Ways to Wellness in Newcastle.
Thank you very much, Simon. Good afternoon, everybody. I'm Chris Drinkwater, Chair of Ways to Wellness. I used to be an inner city GP in Newcastle, but have now migrated to the voluntary and community sector. Next slide, please. This is basically Ways to Wellness in April 2015. And just as a warning, I have to say it took us over 2 years to get to this point. And going around this at the top, commissioners, we had to put together the funding for Ways to Wellness in terms of 2 million from Commissioning Better Outcomes Fund, 1 million from the Cabinet Office Social Outcomes Fund, and we had to persuade the CCG that we needed a 7-year contract if we were going to be able to demonstrate that Ways to Wellness was effective in tackling long-term conditions in inner West Newcastle. The other key bits of this is that we have an outcomes contract. Outcomes contracts, essentially, we only get paid when we deliver specific outcomes. We're not paid necessarily on the numbers of people who attend. We don't have a grant. We don't have a block contract. We're paid if we deliver outcomes. And just again, going back to GP practices, we decided at a very early stage that we were going to target a defined population, 16 GP practices. It was 18 when we started, but mergers and changes in practices, we're now down to 16, but covering a population of 140,000 people. And Ways to Wellness is a special purpose vehicle. We don't employ link workers directly. We subcontract with local providers of link workers who are then attached to and work with practices, those 16 practices. And it's essentially the Ways to Wellness special purpose vehicle, 3 staff, chief executive, a finance director and administrator, an experienced board, a management information system, marketing activities, link worker training, and funding for some patient-related activities. And I think perhaps you can see why it took us over 2 years to put all of this into place in terms of setting up Ways to Wellness as a charitable foundation, recruiting staff, recruiting the board, liaising with the general practices, commissioning, procuring our service providers, and a lot of discussion with local people with long-term conditions and with local voluntary sector providers in Newcastle. Next slide, please. In terms of our referral criteria, and unlike the other 2 projects that you've heard about, we have very specific referral criteria. The reason for this is that in terms of the financial modeling of our outcomes contract, we needed to know the population that we were targeting. And within that 140,000 people, there are 14,652 who are on long-term conditioned quality and outcome framework registers. North of England Commissioning Support has a system called Radar, which, if you like, sucks data out of GP systems and collates it all so that we know the total numbers of people with our specific long-term conditions, COPD, asthma, diabetes type 1 and 2, etc. We agreed we would target people aged 40 to 74. A lot of discussion with the CCG about this. The CCG wanted us to target what they called the frequent flyers, frequent attenders, or if you like, people at the end stage of their long-term conditions. We said that if you were really going to have an impact on long-term conditions, you needed to engage with people early in the development of their long-term conditions so that they didn't end up, if you like, with ill health for long periods of time. And then there were some further prioritized referral criteria: social isolation, loneliness that you've already heard about, poor understanding of conditions, anxiety or depression, poor health, poor English literacy, etc. Next slide, please. Service characteristics in terms of what do our link workers do, and currently we have sort of roughly 23 full-time equivalent link workers serving that population. 18 to 19 months average length of stay on the service, 4 to 5 goals average per patient, 60% of patients are signposted, and I think one of the important issues there is 40% of patients are not signposted. A lot of this is about people doing their own, if you like, self-directed activities, or beginning to take more control of their own lives and do things that they want to do, rather than be necessarily referred to a service. Average link worker caseload is around 100, and I'll come back to that later. And qualitative and quantitative data, we have Newcastle University doing an independent evaluation funded by National Institute of Health Research, but some of their early stuff shows that we have a group of patients with high historical use of hospital services, higher levels of comorbidity, with 55% having 3 or more long-term conditions, problems with stress, anxiety, and depression. And I think one of our issues is if you have a physical long-term condition, your mental health gets neglected. If you have a mental health long-term condition, your physical health gets neglected, and never the twain shall meet. And then multiple social and economic issues, including debt, housing problems, low income, and unemployment. Next slide, please. Service metrics just in terms of patient numbers. Referrals to date, this is 31st of December 2020, 7,561 referrals. Engaged patients to date. Not everybody who is referred engages with the service. Some of them don't even get to see the link worker because for whatever reason they decide that even though the GP's referred them, they don't want to take up the referral. And some of them, having sat down with the link worker, decide this is not for them. But roughly, there's a sort of around a 75% take up from the total population. Currently engaged patients, people come and go on the service. So at any one time, we have around about 2,500 to 3,000 patients. And the practice referral rate, again, this is the value of an in-house management information system. And we've spent a lot of time putting together our management information system. You can see a significant difference there in terms of referral rate from practices, some with very high referral rates and some with very low referral rates. You can almost sort of characterize them as sort of early adopters who've systematized, a group in the middle where 1 or 2 people in the practice have sort of bought into social prescribing and refer patients, but the practice hasn't systematized. When 1 or other of those people is away, referral rates fall. And then there's a group at the bottom who tend to be, if you like, the failing practices, and the practices who've ended up merging with other practices in our case, or in 1 or 2 exceptional cases, practices who will be saying, why is the CCG spending all of this money on social prescribing? We're doctors, we should be doing medical things, you should be spending more money on us rather than on social prescribing. So there are some cultural issues there to be addressed. Next slide, please. Our key outcome metrics, the metrics on which we're paid. The Wellbeing Star. Why did we pick the Wellbeing Star? We looked at a number of possible outcome metrics, and the logic model here was, the argument to the CCG was, if you don't make changes in people's quality of life, you're hardly likely to have any impact on the way that they use hospital services. So quality of life comes first, and if you improve quality of life, the logic model suggests that you might make a difference to hospital costs. So we looked at a whole range of possible outcome metrics. and ended up with the well-being star. Reasons for this are partly that we could convert this into a number. Each of the 8 points of the star, number 1 to 5, there's a training package delivered by Triangle which goes with this model, so there is some quality assurance in there. And equally, there is a quality assurance model in terms of ensuring that the link workers touch all the bases in terms of the social determinants of health, where you live, money, friends and family, etc. So that was the reasons for choosing the well-being star. Secondary care costs, and the 30% and the 70% on that side. 30% of our payment comes from the well-being star, 70% of the payment comes from secondary care costs, basically. So in terms of our setup, it was almost essential that we made some savings in secondary care costs in terms of savings in scheduled and unscheduled admissions, outpatient and A&E costs, compared against a matched cohort. Our 16 practices are all in Inner West Newcastle. Our control cohort are similar practices with similar socio-demographic makeup in the east and north of Newcastle. So we're paid on a cohort comparison model, basically. Next slide, please. Looking at the data to date in terms of outcome 1, impact on well-being, over 4,200 patients have completed 2 or more well-being star assessments, approximately 6 months apart. We don't stop at a second well-being star assessment. Some people have completed as many as 8 well-being star assessments. And the average patient improvement is 3.4 points, which is 12% overall domains of well-being. And that's more than double our target, which, as you may remember from the previous slide, was an increase in 1.5 points. And perhaps not surprisingly, and again, one of the advantages of the well-being star and having an in-house management information system is that you can see that percentage improvements in lifestyle are much greater than at the other end of the scale where you live. It's much more difficult to change where you live than it is to change your lifestyle. So that in itself, I think, is of interest. Next slide, please. And this is really the nitty-gritty in terms of the savings. When we have data going back to the year before we started, 2014-15, we launched in 2015, year 1, and essentially this is part of the argument to the CCG for a 7-year contract. We said you're hardly likely to make any savings in secondary care costs within the first 2 or 3 years. We need a 7-year contract to show whether or not you're going to make savings in secondary care costs. And to an extent, the big lottery funding, Cabinet Office funding, was all loaded to the front of this model. So the CCG only started paying once we began to make savings in secondary care costs, so that they were paying for savings in secondary care costs rather than setup costs, basically. What you can see here is that there is a divergence, if you like, from year 3 between the 2 cohorts, the intervention cohort and the control cohort, basically. And across the 4 eligible ways to wellness cohorts, 14,652 patients, this equates to an annual secondary care cost reduction of 1.56 million in 2019-20. And the cumulative costs avoided for all secondary care around 4.6 million over 5 years. So it's essentially in terms of proof of concept and demonstration that improvements in quality of life through social prescribing reduces the cost of secondary care for patients with specific long-term conditions, that that has now largely been accepted by the CCG, with agreement that we're now sort of sitting down with them to look at exploring extension of this contract, basically, and moving this contract to a long-term basis. Finally, just some reflections on all of this. Financial modelling of an outcomes contract is complex. There are a whole bunch of issues in terms of how do you cost improvements in the wellbeing star? How do you cost savings in secondary care against a control cohort? Are those costs reasonable? What are the and as part of commissioning for better outcomes, we clearly had 1.1 million from investors. How do you cost in the return to the investors, basically the social investors? So, how do you ensure that you're paying your providers and your link workers adequately are all part of that package. Dedicated real-time management information system is critical to all of that. Targeted population health management approach with a clearly defined population. And I think there's some interesting issues here in terms of there is a tension between a focus on individuals and a focus on the total population. And some of that comes down to these issues around caseload, case mix of link workers and how that works, because clearly within that population of people with long-term conditions, there are some people who are managing much better than others and need much less support. So working through those issues about case mix, caseload, and if you like, assuring that we're, if you like, supporting autonomy and agency rather than creating a dependency are all fairly critical. And I think the other sort of important reflection for me there is that increasingly I've come to believe that the link worker, rather than the activities, is the intervention. The relationship between the link worker and the client or patient is critical to what happens next, and whether or not activities are taken up. Supporting people into those activities through the link worker, and the link worker following up and, if you like, adapting, changing, being prepared to work with the patient in terms of a real personalized, bespoke approach to those individuals is incredibly important. And the final bullet there, culture change within service providers and the local community. I think I'd reflect some of the things that the previous speakers were saying around some of the, if you like, unexpected consequences of all of this. Because we've now had over 7,500 referrals, around about 6,000 people who've gone through the program. What we're seeing is graduates of the program now volunteering, running activities within their own communities, and some of them going on to say, I want to be a link worker, how can I train to be a link worker? And I think much of that is around sort of generating local community activities within communities that don't necessarily have significant numbers of assets. It's not about referring people to a central point where they can get activities. It's about the link workers, if you like, acting as community asset builders, and really sort of gearing up those communities and improving the range of assets and opportunities within those local communities. And I suppose the other bit within that is culture change within the general practices. Over the 6 years to date of the contract, there have been really significant changes in terms of buy-in from local general practices having much better relationships with local voluntary sector providers and doing all sorts of things off their own bat that they might not otherwise have done. So I think there are a whole bunch of issues about other benefits of this sort of approach. And final slide, which I can leave with you, is just some quotes from patient and GP satisfaction surveys. The feedback loop from link workers to providers, the feedback loop from patients to link workers, the feedback loop from Ways to Wellness to GP practices and to the CCG is all a critical part of how this works. Thank you very much. And I think we're going on to a Q&A session with Jane.
Yeah, we are. Thank you very much, Chris, Simon, Catherine and Dan for those presentations. We've had lots of comments, positive comments in the chat, and also comments saying there's so much information, which there is in all three of those presentations. And there will be information coming around. There are various links in the chat, but also about how people can keep in touch. People have been doing stuff on Slido, and I don't know, Berenice, are you able to share the word cloud at the moment?
Yes, just give me 1 second.
Yeah. And if speakers would like to put their cameras on, that'd be great, thank you. So we actually, I think this is right, we had far more on the challenges, didn't we, than the opportunities. And I wonder, Dan, whether you'd like to just sort of comment on that, cloud, some of those things coming out there.
Thank you, Jane. Yeah, absolutely. I think that there are very, very significant challenges to applying outcomes measures, particularly across systems. And I know that, for example, NHS England are very interested, and we had an interesting conversation, Chris Drinkwater and ourselves the other week about this, about the desire for systems to have consistent measurements across, in the case of England, across the whole of England and across social prescribing, and the real challenge around doing that. And I think what's very interesting about these three examples that we've got is that they've actually been developed within local communities. One of the challenges, of course, of any research and evaluation system and monitoring system is around the resources needed to do that, and putting the systems in place, the data systems as well. And I think that's something that certainly we would be very keen on helping to support people with, is how to learn from us, and that and maybe Simon and Chris as well, about the systems that would be helpful for them to implement outcomes measurement as well. I don't know if there are other comments as well from other presenters. Yeah,
Chris, I think.
Yeah, I think the only two things I would add to what I've said before in terms of the wellbeing star. One, our providers get paid on completion of a wellbeing star. So that's, if you like, a financial incentive to complete the wellbeing star. The second issue is that the link workers like the wellbeing star because it helps them to see where the strengths and weaknesses are when they're sitting down talking to patients, and it helps them to action plan with the patient and to set goals and targets basically with patients.
Thanks, Chris. Simon.
I would just say I'm a fan of the wellbeing star model. Just about the capturing, I think I said in my presentation, the importance of having a really flexible partnership CRM system or case management system, whatever you want to call it, data management system is super critical. And then on the softer outcomes, I mean, we capture lots of stories, we interview people, we film them, we get them to tell their stories and play them back to others. That's the most powerful way, I think, of capturing the softer outcomes. Thanks.
Thanks. Okay, can we, Berenice, can we see the opportunities then in the word cloud? And people can still keep adding in, can't they, to these? Is that right?
Yes, the poll is still live.
Yeah, they're still live. And then there's a couple more questions going to come up before I also send them the questions that have come out from Slido around. So in terms of the opportunities, there's nothing so much really come out, just a lot of opportunities, but nothing really heading, can't see anything sort of standing out on that one.
I've just noticed something. There's something that I'm quite surprised about the challenge and the opportunity slide. Cost of delivery. that very much feels to me to be a challenge. And I was really surprised to not see it on the other word cloud. And now it's here. So I don't know if it's in the right, maybe it's just in the wrong slide. Or maybe it's about improving cost of delivery rather than the cost of outcome measurement. But I am genuinely surprised that people haven't raised cost as being an issue to capturing data.
Right, thank you. And Simon, did you want to come in?
Just there's a couple of words that popped out at me. One was assets, and I think Chris mentioned it as well. In our link earlier, we've done a lot of work around building the assets, particularly the people being the biggest assets. And one of the most important elements of that is celebrating people's contributions. And I think if we do anything else in the community space, we need to celebrate and value the contributions of the people.
Thank you. Yeah. So Berenice, do you want to put the other questions up? And while you're doing that, I want to take some of the questions that have been put through to the webinar. And there are so many, but the one that's got the biggest number of votes is around the 3 metrics you think are the most valuable in measuring change. So sort of like honing down, because you've all presented something that's really comprehensive in terms of measurement. But can I put you on the spot, Chris? Turn to you first. What would you be your top 3?
My top 3. I think the wellbeing star would be top. I mean, sort of where we've got to in terms of year 6 of our contract and looking at where we go next in terms of ways to wellness. The CCG has largely accepted that we don't need to do measurement of secondary care costs any longer because we've made the case for this population of patients, i.e. people with long-term conditions. And certainly that's a very important group within the population who have all sorts of issues and problems that need to be addressed. And so wellbeing star would be top. I think looking at other measures, if you're going to go quick and easy, then ONS4. The PAM, my experience of the PAM has been fairly negative in as much as people don't like it. It doesn't really help to plan, and it doesn't really help in terms of how you target patients, basically.
Thank you. But I think it's good to get that, because people had asked about the pragmatism. So you're saying the outcome star is quite pragmatic, but some of the others are less. Catherine, because you've been wrestling with this, haven't you? Sort of filtering down, I don't know, not hundreds, but many indicators to come down with the indicator set. What are your top 3 metrics?
I'm going to give a bit of a politician's answer to this.
All right. Oh no.
Because it varies. It depends on the activity that you're trying to measure.
Okay.
And in Bromley by Bow, as I said earlier, we're measuring change from a whole heap of different projects and activities. And we've got approximately 40 at the moment that we're measuring change from. And it also depends on the length of time, the type, how the intervention is delivered. So we measure change, for example, from one social prescribing conversation, which could be an hour long. And there are very few indicators that are captured at that point in time. So that's probably the activity that has the lowest number of indicators. And what Bromley by Bow does is, because we want to capture attribution, we ask people whether a change has occurred as a direct result of engaging with Bromley by Bow. So rather than taking a pre and post measure, from which, unless you have a controlled trial, it's going to be quite difficult to measure attribution. That's the approach that we take. So I'm not sure that I would choose ONS4 if I was going to just choose 3. But yeah, just summing up, it depends on the activity that you're wanting to measure change from.
Thank you. I mean, it comes across to me and from the questions that there are no simple answers here, and it's a balance, isn't it, to be sought between different, because we can't measure everything. And that's what one of the questions was, can we apply the 2080 principle? I mean, Simon, your evaluation approach looks incredibly comprehensive. What are your sort of top 3? And, you know, if you had to do the 20-80 principle.
I'm not sure I've captured the 20-80 principle. But
no, well, don't worry. Yeah, but yeah.
Is that spending more time doing the work than
no, apply, is that, was there a way to apply the 20-80 principle to apply 20% of the measurement to get 80% of the information / certainty?
Well, I'm going to vote with Chris.
Yeah. Okay.
Around the outcome star.
Yeah.
I mean, I think there are a number of different stars, aren't there? But actually, it's something you could use very low cost. You don't need to be buying something. You can just create a star. I like the idea of the people self-selecting some of what would be some of the star points. And I couldn't actually see it on the slide, but I suspect some of the stuff in the star is similar to what's in the Bromley by Bow and similar to our more questionnaire-based approach, which is asking some sort of key questions around how things are changing for you. So I think it's person-centered enough for me. I would definitely want stuff in there around contributions. The bit I'm trying to amplify here is in our model, as Chris also said, we're trying to enable the people to be active contributors. And actually, if you keep that philosophy, rather than keep looking at people as people who need to be fixed by others, we want to measure that journey. So some way of capturing contributions. And slightly I guess Chris has proved the case with his local health and care system. But for me, the other one is the cost saving bit. So for lots of people on this call, I suspect it's convincing those colleagues and partners in health and care, commissioning land, etc., that this work is actually making a difference. And when we looked at our model, similar questionnaires have been done in Cornwall, but then some of that data was questionnaire based and it wasn't substantiated by the cost benefit analysis, which is why we captured the NHS numbers and wanted to do that cost benefit analysis. And there's lots of questions around social return on investment. We could have done that, but we had so much already, we couldn't incorporate that as well.
Yeah, there have been a lot of questions and in the chat about social return on investment. So I'm glad you sort of touched on that. And I'm wondering, Dan, you know, what your thoughts are about how important is it for Bromley by Bow to demonstrate that kind of return on investment? And perhaps Dan, then Chris, because you've also got that in your, has that been important for your health, you know, to convince the health system?
Yes, and we have attempted that in the past, and there's one of the evaluations, I think somebody's put a link in the chat actually to one of our evaluations that does include that. And undoubtedly that is important, but I think for us the first stage is not that probably. And I think it's also true to say that it's very, very complex measuring cost saving analysis as well. But just going back to the previous question, I mean, I think we could almost distill the outcome measures of Bromley by Bow. There's a lot about people's sense of community and belonging to community. There's a lot about people's sense of agency and building skills and capabilities and relationships within community. And then there's something very critical around people's basic needs. It has to be said that in all of this, there's a real need for people to, and of course, some of that has been very, very negatively impacted by the situation under austerity for the last 10 years, probably, and then more recently by COVID as well. But undoubtedly, yes, at some point, economic measurement is very, very critical as well. But I'm not sure that's our starting point.
Thanks, Chris.
Yeah, I think in terms of our local health system and our initial discussions with the CCG, they wanted, as the finance director said, to ensure that Ways to Wellness washed its face and save them money, basically. So that economic bit was key. And at that stage, they were more interested in saving some secondary care costs because the contract for GP services was held centrally rather than by CCGs. So their main financial pressure was around secondary care costs. I think sort of the other ones to kind of add to that in terms of just the longer term, we had a lot of discussion with the CCG in terms of this is not a brief intervention. We want to show that change is sustained and maintained rather than just maintained for 6 months or 12 months or a short period of time, which was why we said we would go on doing well-being stars. And to an extent where we've kind of moved to is that we now have an active intervention phase where the link worker is heavily involved. We then have a keeping in touch phase where if things happen in that patient or client's life, they can get back in touch with the service, or the link worker can follow up at sort of a 6 months and say, how's life, how's things going? And then we have discharge when people are really confident, but just because they've been discharged doesn't mean that they can't come back in again if things happen in their lives.
Yeah, and it's that sort of like people live lives, don't they? And the intervention's only a small bit of it, but somehow other intervention studies don't always reflect that at all. And we've had some questions about timing of measurements and everything. And I don't know, Catherine, do you want to sort of start us off on that? You know, when's the best time to do that second measure?
Again, it varies according to intervention. So at Bromley by Bow, each project has a specific ideal time by which a change is likely to have occurred, because we want to capture and ask data, change data and ask questions at that point. There's no point in asking the question beforehand because that's going to invalidate the data. So we've developed an approach that's bespoke to each activity, and I drew attention earlier to social prescribing. We measure change at the close of one conversation, and then we measure change after all conversations have occurred. And for anyone on the call who doesn't know about social prescribing, that can accommodate up to 6 or more hour or more long conversations. So it's bespoke to the activity. So I would have to spend quite a lot of time going through all the ins and outs of the different activities to explain that. But it's, as I say, it's at Bromley by Bow, it's bespoke. We capture baseline data and registration data at the start, and then we capture data when a change is realistically and likely to have occurred.
Thank you. I mean, that's one of the challenges for measurement, isn't it? In terms of people's journeys are all really different. It's the whole point of doing this sort of work. Chris?
I take it back further in terms of in terms of that initial conversation. One of our messages to link workers is you don't necessarily have to complete the wellbeing star at that first visit or first conversation with the client. It's about building the relationship, and when the client patient is comfortable about that relationship, that's the time to complete the wellbeing star and to think about sort of an action plan and beginning to talk about sort of what might be sensible goals to be set and how you then move forward. So if it's really going to be bespoke, the relationship is critical.
Thank you. There's some questions about that have come up in the chat about control groups and comparison groups and how important that is. Should we be trying to, obviously we want to encourage sort of, good research on this and so on, but what about comparison and so on? Simon, what was your sort of, did you have sort of constraints from your funders? Were you expected to provide comparisons with other areas?
No, the reason the 14 sites all had the same questionnaires, although the one I posted was a slight adaptation, and there were entry questionnaires, and I think they were done 6 monthly, and there were exit questionnaires or follow-up questionnaires at periodic times. I'm not sure I'd necessarily do it. I think Chris got a very important point around, but we had no control group. It's just a comparison, because our project was about trying to learn kind of what works. I do think there is an issue though with this attribution point, because when you're working with people and their complex lives in their complex places and all the rest of it, it's very difficult to gain attribution. So we're using sort of health methodologies and trying to transpose those into community settings, and I'm not sure we'll ever get there. So there's a bit of a question mark for me, which is why I'm interested in the contribution idea of ripple effect mapping
rather than the attribution. So Chris, about your thoughts about, because you've been part of National Institute of Health research trial, haven't you? You know, you sort of put your fingers very much into the sort of funded research part, yeah.
What's the in terms of control groups? I don't think it should be necessary for everybody. I do think there's an issue about sort of proof of concept that may need to be done with research colleagues looking at specific populations. And I suppose some of my thoughts around the way forward for Ways to Wellness is that we need a bit more research around sort of social prescribing with the older population, particularly around loneliness and social isolation. We need more around social prescribing and people with mental health problems. And equally, there's a growing amount of work around social prescribing and young people and whether that's an effective. But those operational models are all going to be very different and will need to have different outcome metrics and different approaches. And you have to be able to define your population if you're going to define a control group, otherwise it's meaningless.
Thank you. And there are lots of questions in the Q&A. Dan and Catherine, some very specific questions that we've got coming up. I'm not sure how we're going to be able to sort of capture those questions, and but they will be able to, that will perhaps sort of shape how, when you're developing tools and so on, to make sure we include that information. But I think, Catherine, there's a particular question you wanted to respond to.
Yeah, something just come up in the chat about social prescribing and how does the approach that we've developed, I don't know if it's at Bonnie by Bo, but you're specifically asking about Sophie and Jane and Katie. But in terms of Bromley by Bo, we're working with the team developing the minimum data set to evaluate social prescribing. So that's the NHS England team. We're also talking with colleagues about the NIHR social prescribing evaluation funding call that was released fairly recently. And as part of that, we're very open to others being able to take our tool and use it. But we're still having conversations about that. It might not be appropriate because it might be our outcomes framework. The tools that sit alongside it have been developed for the Tower Hamlets community at this particular point in time, and things might change. We might want to develop the framework again come another few years. But I just wanted to let you know that that's something that we are talking to about, both with NHS England and also with a team of people who are interested in the NIHR funding call.
Thank you, Catherine. And I just thought to wind up the discussion because we could carry on a long time, but we haven't got the time to do it. And I'm going to ask the speakers, because a lot of people, when they said what they're interested in the for this webinar, mentioned that they wanted to know what good practice was like. So I'm going to ask all of the speakers to just say, to sum up in one sentence, to give us one sort of takeaway thought about what they think good practices in measurement. And I don't know whether anyone wants to kick off with that. Simon, you're looking like you might, you've got a smile, so you might kick us off on that. Well, what would your one takeaway point be for good practice? Thank you.
I think we need to make it doable.
Yeah.
So some kind of consistent, fairly simple way of doing it. So as many people as possible can be capturing the same stuff would be my answer.
Right, thank you. Catherine?
I think focus on what realistic change is likely to look like. That's what I would say. And when you've completed a program, what do you want to be able to say about it? Put it into a sentence and then backtrack from that. Otherwise, just as a supplementary bit of my sentence, consistency and staged processing, making sure you involve the people who are providing the data.
Thank you. Chris?
I think any outcome measurement needs to make sense to both link workers and the clients and the patients they are developing a relationship with, and needs to enhance that relationship rather than get in the way of that relationship. And too often sort of measurement can get in the way of building the relationship. And somebody in the chat has said they're a bit worried about the cost of the license for the Wellbeing Star. I think my response to that would be perhaps NHSE should be buying the license for the Wellbeing Star rather than buying licenses for PAM, which is a North American model.
Okay, and Dan?
I think for me, it would be that the outcomes frameworks need to be taken back into the communities that have helped to devise them. The data should be shared with communities. It should then start to form part of a dialogue, I think, between the organisations within communities, and within that I include NHS and local authorities, about what's provided within communities. And this allows communities to be co-producers of the services and how those services are provided within their communities. And I think the outcomes measurement and the outcomes measures provide an ideal opportunity to generate that dialogue and that conversation with communities.
Okay, thank you very much for that, and some really lovely points, I think, to end it on, and a lot of thought, things to think about from people. Berenice has put up how to stay in touch. There have been lots of links in the chat. Bromley by Bow have committed to forward the slides, and I think collate some of the links in the chat that have gone round, so everybody should have access to lots of information. I do encourage you to sign up to Bromley by Bow Centre Insights. There are lots of Bromley by Bow, an amazing leader in the sector, putting on lots of webinars for shared learning and training, and lots of information there, which I always find really useful. And I just want to end by thanking our participants, because people have been really engaged and put in loads of useful information. I mean, this webinar has been stuffed full of information and thoughts about things, but I particularly want to thank our speakers, Chris, Simon, Catherine and Dan. Thank you so much for your wonderful presentations, and to hear that sort of depth and breadth of experience. I think it's made it a very special webinar. So I will close now and hope everybody, it's nice and sunny where I am, so I hope everybody gets to go out in the afternoon, and I can see Catherine's got her hand up, and enjoy the sunshine. Catherine.
Yeah, I mean, apart from saying thank you very much,
Oh, sorry.
there are a couple of questions that are linked to in the chat, which are very helpful to share with our funders, the answers to our funders. Please, can people answer those questions before they go? I can see the participant number rapidly dropping. Please, before you go, could you answer those questions?
Okay. Yeah, and I should have said, there's one more thing I should have said, is there's a further webinar in May, the links are there, and that's going to be focused much more on how these outcome measurements that have been developed in Bromley by Bow can be used in services and the learning from practitioners. So please do sign up for that, or pass that link on to other people. So thank you everybody for that, and thank you again to the presenters.
And thank you, Jane, for hosting and chairing as well. It's been fantastic.
And I should say thank you to Berenice, because she's kept us all going on the technology so smoothly. Thank you.
Great.